WAG for recognizing that these panels and the data presented here are critical to disseminate in a timely fashion and really can't wait until we can be in person again. So I appreciate the effort to make these virtual. I wanted to take this moment to remind all of us of the importance of the work that we do in the context of crisis and in the context of this pandemic. Even before the pandemic, close to 2 billion people were living in fragile contexts worldwide, and close to 200 million of those were in humanitarian settings. And as all of us know on the call, approximately 1 in 4 are women and girls of reproductive age. So we know that women and girls affected by crisis want and need access to family planning and will use it if it's available. We know it's feasible to provide comprehensive family planning services in challenging humanitarian contexts. That's what you're going to hear about today. Yet that access remains a gap. Thanks to the hard work of the IWAG Steering Committee and the sub-working groups, the revised 2018 Minimal Initial Service Package for SRH mandates, finally, the provision of family planning services from the outset of a crisis rather than later on. Obviously, this won't be sufficient alone, but this is a very important step. I think this pandemic has shown all of us that all of us, all countries, all societies, and all systems are vulnerable to emergencies. And all countries must be ready to provide essential services, including SRH. So today we'll hear from 4 presenters on how they and their teams worked to learn more and provide SRH services in complex settings. Can I change the slide, Erin, or can you? Okay, great, okay, perfect. So our presentations today cover diverse areas, conflicts, and approaches. And to that end, let me introduce our panelists and the titles of their presentations. Our needs went beyond Ebola is the first presentation, Women's Perspectives on Seeking Family Planning During Sierra Leone's Ebola Outbreak. This will be presented by Gillian McKay. She's a research fellow at the London School of Hygiene and Tropical Medicine. The second presentation will be Meeting the Demand of Women Affected by Ongoing Crisis, Increasing Contraceptive Prevalence in North and South Kivu in the DRC, and this will be presented by Jessica Kaseka from IRC. The third presentation will be Introduction of Subcutaneous DMPA, Self-Injection in Humanitarian Settings, Early Lessons from Uganda, which will be presented by George Barige. And the fourth is a presentation entitled What Women Want, SRH Service Delivery Through Integrated Women and Girls Safe Spaces in Bangladesh. And with one of the things I want to remind everybody is that we are to request that you mute your mics if you're not speaking. We don't have the webinar feature, so you have to be responsible for muting your own mic. So far, so good. And place your questions in the chat. I think that that will be easier. We'll address all of the questions at once at the end of all of the presentations. We won't take questions in between each presentation. So save your questions to the end, although you can put them in the chat as we go so you don't forget, but we won't address them until the end. We have a total of 90 minutes, so we should have time to have a robust discussion towards the end. And I forgot to say that Nasreen and Terry will both present for our last presentation of What Women Want. So with that, I'll hand the mic over to Gillian McKay, who will have the next presentation. I'll take my video off for now. If you are presenting, please have your video on if you don't mind. That will help people, I think, to hear and understand better. And then the last bit is we will record this meeting. Thanks.
Thanks so much, Eva. Just waiting on my slides to come up.
Just one moment on the slides.
No problem.
Jillian, I'm not sure I have your slides. Do you have them open on your computer? I can easily make you co-host for broadcasting.
I have them if it's helpful for me to project them.
All right, Megan.
What's easiest? I also have them, so let me know.
You pick, Megan, or Jillian, whatever's easier for Megan to project or for you to.
I mean, I'm happy to do it.
Okay, that sounds
gives you more
great.
control.
Sure.
Wait 1 second, Jillian. All right, Jillian, you should have
I'm
broadcast access.
now the co-host. You know, you would think after many, many months of this, I would be much better at being able to do this. So, share screen. Can you guys see that?
We see it. Thank you so much.
Yeah, looks
Of
great.
course. Great. Okay. Wonderful. Thank you so much. So as introduced, my name is Gillian McKay. I'm a Doctor of Public Health candidate at the London School of Hygiene and Tropical Medicine, where I am trying to finish up my thesis for this data that I collected back in 2018, which feels a bit of an eon ago now. When I was collecting my work. So this was done in Sierra Leone, and it's specifically around women's experiences of seeking family planning in the context of Ebola, with the outbreak that ran from 2014 to about 2016. Oh, next. That worked, right? Okay. Great. So just to set the stage a little bit. So thinking back, goodness, 6 years ago now when the outbreak started, Sierra Leone was a country of 6.2 million people. They had some unfortunately quite dire reproductive health indicators, with one of the highest maternal mortality rates in the world, as well as a very low percentage of women who are using a modern method of family planning. Now, as much as these indicators were not great, they were very much an improvement over what over the last kind of 10 years at that point, since the end of the civil war in that country. So things were on the up and up, and unfortunately the Ebola outbreak created yet another shock that delivered quite a severe challenge to the country. Ebola came to Sierra Leone in 2014. It affected the three countries around, the Mano River region countries, Liberia, Sierra Leone, and Guinea, and did have a few cases in other countries, but the majority of the cases were in those three. In Sierra Leone specifically, there were approximately 14,000 cases and about 4,000 deaths. There was a very large increase in economic instability as a result of the outbreak. Interesting, I suppose not that dissimilar to what we're seeing in COVID now, to be honest. Flights were closed, flights were stopped, borders were closed, large industries shut down, including industries including mining, which is a really important one in the country. Markets were closed. There was large transport restrictions leading to challenges in selling people's goods, etc. Schools were also shut down for over a year, leading to a number of different studies that have shown an increase in adolescent pregnancy as a result of that, with young girls losing the kind of protective environment of schooling. And in addition to the deaths that were directly attributable to Ebola itself, there were quite a lot of additional kind of non-Ebola healthcare deaths. So this included, these are sort of modeled numbers, but probably reasonably accurate, an additional 3,600 additional maternal, newborn, and stillbirths, and 2,800 malaria, tuberculosis, and HIV deaths. Now, most of these were related to closure of healthcare facilities, inaccessibility of healthcare facilities, fear of attending healthcare facilities in the midst of the outbreak, etc. In a country that already struggled to have sufficient numbers of skilled healthcare workers, tragically 7% of doctors, nurses, and midwives passed away during the outbreak. And unfortunately, a number of them passed away in the early days of the outbreak while providing maternity care. I have a slide on this in a second to explain a bit more about the interactions, the complex interactions between Ebola and pregnancy. But just to kind of preface it, that in the early days of the outbreak, when there was not a lot of personal protective equipment available, or very little, a pregnant woman who potentially had Ebola would arrive at a health first facility to ask for care. Healthcare workers would, deliver her baby or support her kind of post-abortion care, which involves a lot of fluids. And unfortunately, in many cases, doctors, nurses, and midwives passed away as a result of providing that care because they didn't have appropriate personal protective equipment. And the kind of, these stories spread like wildfire around the country, leading to a lot of healthcare facilities refusing to support or closing their doors to pregnant women when they felt unsafe to be able to provide it. So just to kind of, dive in on that a little bit to explain, because this is important for later, what happens in pregnancy and Ebola. So the Ebola case definition, how we define if somebody has Ebola or not, or more specifically, if they should get a test or not, includes unexplained bleeding and spontaneous abortion as automatic. You have to get a test for Ebola if you have either of these symptoms. So both of those things would happen in the case of, say, an obstetric complication, but also in a lot of other cases. You know, women bleed for many reasons, including breakthrough bleeding for family planning, etc. Now, pregnant women who have Ebola, who actually carry the virus, unfortunately often miscarry or have obstetric complications related to the infection. But also you can have obstetric complications for other reasons as well. You could have a spontaneous miscarriage for other reasons. But it's very difficult to differentiate obstetric complication and Ebola, meaning that basically any woman who came in with any kind of bleeding would be told, go for a test. We need you to get an Ebola test to make sure to, you know, not spread it at the healthcare facility. And this caused a lot of challenges, as we'll see in a second. So this research, as I said, was part of my thesis and is part of a bigger project looking kind of across the health system for reproductive health, but specifically wanted to look at barriers and facilitators of receiving family planning during the Ebola outbreak, and to try to identify some lessons learned and recommendations for how family planning policy could be improved and prioritized in future outbreak responses. So this was through a policy review of Ebola and family planning policy in place at the time, in-depth interviews and focus group discussions. And this all took place, as I said, in kind of early 2018, so a couple of years after the end of the outbreak. So I'll go through some results kind of in two main camps, proximities to Ebola and motivations. So in the proximities camp, we have proximities to health facilities. So for a lot of women, taking family planning was a really good way of avoiding Ebola spaces. If, as I said kind of earlier, you know, Ebola and pregnancy kind of complications are very difficult to differentiate. So because you wouldn't necessarily be getting care if you were pregnant, there was a lot of women who said, well, this is a really bad time to be pregnant. So let me take family planning to avoid the kind of potential risk of not getting appropriate pregnancy care. And, you know, even kind of early signs of pregnancy, morning sickness, etc., could involve people being sent away to an Ebola treatment center for testing. And there was a lot of fear of those Ebola treatment centers because unfortunately, in many cases, especially in the early days of the outbreak, people would be taken to those centers, they would pass away, and they would never kind of return to their home and family. So family planning was a good way of avoiding having to interact with health facilities. But also the converse was true for other women, that family planning was kind of health facility, accessing family planning at a health facility could put you at risk of contagion or contamination. So families saying, you know, don't go for your family planning to the clinic, because if you go, you could get sick from being at the health facility. Who knows who else is sitting in that waiting room with you? Or if you go to the health facility, they're going to test you for Ebola, you're going to be sent away to the treatment center, and we might not see you again, or you'll get contaminated. So some women, to avoid the kind of health facility association with contamination, chose to see the nurse. Maybe, you know, you'd pop over to her house at the end of the day and say, can you give me my family planning in a private space? And that worked for some women. And then you had proximities to healthcare workers. Now, unfortunately, many healthcare workers were seen as vectors of disease during the outbreak. Because, you know, unfortunately, a number of them had become infected and potentially spread to other members of the community while they were ill. So some women chose to avoid healthcare workers as much as possible. Maybe they were on an injectable method before, where they had to go to the healthcare worker to get it. Well, they chose to switch to pills because they could get those from the pharmacy and it didn't involve any physical contact. And also that kind of, there was a conflation a little bit of, you know, family planning injections and general injections and Ebola. Lots of rumors swirling around that healthcare workers were injecting people with Ebola, that they were somehow getting money out of Ebola. So it was important to trust your healthcare worker to make sure that you weren't going to be given an injection of something that wasn't family planning, that was in fact an infectious substance. And then I found as well that familiarity with healthcare workers really helped to increase trust and made that proximity issue kind of reduce the proximity issue. If you were a nurse or a healthcare worker from that local community, you spoke the local language, people would come and see you to get their family planning because they trusted who you were. And even if you were necessarily wearing a lot of this personal protective equipment that was really anonymizing and fearing, in many cases that could actually overcome the fear that women had, so they would still come to see you in the midst of the outbreak for your family planning. Although in some cases, of course, as well, the PPE, even if they knew you, it was still too scary to overcome. And then we get into the kind of motivations camp. So there was motivations to prevent, prevent meaning the term that's often used in Sierra Leone for using family planning, as well as motivations not to prevent. So for some women, the side effects, the kind of breakthrough bleeding side effects of family planning were too close potentially to Ebola, because they could cause that breakthrough bleeding that would potentially be considered unexplained. So if, the risk of taking family planning was too high in that context. Although I did find that healthcare workers who were a little bit more well-trained in how to counsel women about family planning could explain better that, this might cause some breakthrough bleeding. It's not actually unexplained, but it's, that was very much about the sort of experience the healthcare worker had about delivering this particular service. Another motivation not to prevent was that for many women, they weren't having sex during that 2 years of the really increased caseload of Ebola. Ebola can potentially be spread sexually. So for a number of people, they said, well, I'm not going to take the risk. They were also living in a no-touch environment, very much a socially distanced environment where everybody was encouraged not to touch. And that was very much kind of aligned with this kind of no-sex space. And some of these women also said, I don't trust that my partner, my husband, or my boyfriend that isn't touching other people when he's outside of the house, whether that's other women or other individuals while he's at work potentially. So it was important for them to really make that space different. So they didn't need to get the family planning because they weren't having sex. And the last one, and I think this one's particularly interesting for those of us who spend a lot of time in the outbreaks world where everything becomes about the outbreak, is that for a lot of women, life just kind of continues on. While we think of the outbreak as responders as the most important thing, that's not really true for a lot of people. This woman, her husband didn't have a child. She wanted to have another baby. It didn't bother her that there was an Ebola outbreak on. So, why would she bother to take family planning, when it was against her reproductive intentions? And I think we tend to forget that a little bit. And then we have motivations to prevent. So when taking family planning, there's two kind of main motivations that came out of the research. Interesting, somebody's clicking on my screen. The first one was around added economic burden. So because the economy had really taken a quite significant fall with markets being closed and jobs being lost, et cetera, taking family planning was a good approach to make sure that you weren't going to have extra children that you couldn't pay for, not only pay for their healthcare, but pay for their schooling when schools came back in, et cetera. So that was a real motivator for some women. And again, with the schooling, schooling had been closed. A lot of women were saying, especially younger women, I really wanted to finish my examinations. And I know that if I have a baby now, I won't be able to go back to school and finish them easily. So it was important to me to prevent so that I could go back to school when schools come back in, however long that might have taken. Kind of almost done here. So we've got some key recommendations that have come on from this research, and I'm happy to discuss these more in detail later. So we have kind of the first one is that, family planning does not become less needed in outbreaks, which is, I'm sure, is the theme that we're going to hear over the course of the next little while. And in fact, it may be a real motivator for some women to stay on their method or potentially try a new method. But it's really important to consider that an Ebola context does change how we have to kind of offer and deliver that service, that whatever method it might be. So it might make sense to emphasize low contact methods of family planning, such as self-injecting contraceptives, where you would avoid the interaction with the healthcare worker directly, but also really thinking about, if there's rumors around injections of disease, which is not uncommon for a lot of different new and upcoming diseases, how are we going to kind of message that from a community engagement perspective very carefully? Thinking about other approaches for distribution of family planning, pharmacies, healthcare workers setting up kind of separate from the health facility, family planning clinics, any ways of sort of working to avoid or reduce some of those fears of contagion that people have at health clinic spaces. And considering the economic impacts and making sure that services are either free or very cheap. Working with trusted healthcare workers to ensure that women continue to access family planning through somebody that they believe in and trust, and who can kind of overcome some of that PPE, personal protective equipment fear. And then kind of concerted advocacy around the family planning and outbreak community to nuance that case definition so that it's not, you know, all breakthrough bleeding is automatically considered possibly Ebola. You know, really thinking about how do we train healthcare workers to ask the right questions so that they can figure out, okay, this is most likely bleeding that is menstrual or breakthrough bleeding. This is not likely to be Ebola bleeding, so that women don't get unnecessarily sent for testing. And just my final message is that, you know, Ebola amplifies. It amplifies barriers and amplifies motivators. And the impacts on care seeking for family planning and for everything really become widespread in an Ebola context, whether it's deciding to seek care, negotiating with your family, or reporting your symptoms, or choice of method. So we've really got to think about how this all applies. And then finally, the individual risk tolerances will vary, and that services must really consider how to adapt for this. Some women will be comfortable going to a facility, and some women won't, and how we kind of find out from them what is needed to make this possible. Thank you so much. I hope I wasn't too over time, and I look forward to your questions at the end. Thank you.
Great, Jillian, thank you. That was a terrific presentation. It's provocative and I think brought up a lot of questions which you will have at the end. I appreciate that you feel that it was eons ago. I think everything pre-COVID feels eons ago, but I'm looking forward to you writing all of this up and getting that DRPH. You brought up self-injection of DMPA. I think we'll have a presentation specifically on that. And I just think your presentation brings up again and again the importance of having women's voices to understand best. So thank you very much for that.
Thank you.
George, are you next? Or okay, you can be next. George's slides are up, and so we'll have the presentation from our PATH colleague next on introducing DMPA self-injection in humanitarian settings in Uganda. So George, take it away. I'll take my video off. And if you don't have bandwidth for a video, that's okay. But if you do, please turn your video on.
I will try, and if the network fails, then I will have to resort to putting off the video. So thank you very much, Eva. Good morning, good afternoon, good evening. Thank you for coming in. I will just take you through our work which we did in the humanitarian setting, specifically for the introduction of DMPA. Next slide, please. Thank you. My presentation will give just a brief on PATH. Then I will also give some bit of a brief introduction on the self-injection with DMPA, and then take you through the core, which is the introduction of SI in the humanitarian setting in Uganda. And at the end, I will look at the resources for the SI, self-injection rather, introduction and scale up. Next, please. Thank you. Just a brief about a background about PATH. We are a global health organization focused on solving the world's most difficult challenges. We develop vaccines, invest just new medicines, and also re-engineer medical devices so that they can actually be suitable in the low resource settings. Then we deliver health services and work with governments and communities in more than 70 countries around the world, largely in Sub-Saharan Africa, and again also in Southeast Asia. Next, please. Next slide. So I think there is some bit of time lag. Yeah, thank you. So as the biggest range of safe and effective products and innovations that enable them to manage their sexual and reproductive health. So under this, PASS develops and advances women-centered contraceptive techniques, empowers women and girls with knowledge to take control of their own sexual and reproductive health. Then we work on increasing access to affordable, high quality and productive health supplies, for example, DMPA. So PASS is a leader in advancing evidence, practice, and policies on self-care for sexual reproductive health, putting the power in the women's hand to manage their own health. Next, please. Thank you. So for the people who have not had any interface with DMPA or Cyanopress, this is a new injectable that is pre-filled all-in-one injection system. It is injected underneath the skin, easier and more comfortable to inject by health workers or women themselves. It is a lower dose of DMPA, and it is 104 milligrams compared to 150 milligrams. Then it has a shorter needle of 2.5 centimeters. And let's talk about the safe injection. We have learned actually from the studies that safe injection is feasible, acceptable, and effective, and can improve actually, continuation, and it can expand access for women and reach more new users. Then also it is included in the World Health Organization book, medical eligibility criteria, World Health Safe Care Guidelines, and it is an approved product in more than 56 countries. So something which is very interesting is that we have learned that actually safe injection is feasible and can actually be done by most of the women. Then also something also which we learned is that safe injection is actually generally safe. So that's why we felt that actually this can actually be able to work and also benefit the people in the humanitarian setting. Next, please. Thank you. So we did work, as I said, in introducing safe injection in the refugee setting in Uganda. Just to give some bit of context that Uganda hosts more than 1.4 million refugees, and approximately 65 are from South Sudan, but there has been a steep increase in the arrival from Democratic Republic of Congo. The refugees here in Uganda reside in settlements with host communities. They have the right to work, to go to school, and access health services within the host communities. So we got some funding or support from UNFPA to expand access of DMPA, including safe injection, as a contraceptive option in two refugee hosting districts. That's the districts of Leone and Kilyandongo. These are located more in the Midwestern and in the northern parts of the country. So in the context, and we did this in the context of the informed choice. So the objectives were to increase access to modern family planning services, including DMPA self-injection at community and facility level. Then the next one was to improve community awareness about family planning services, including self-injection. Then the last objective, which was the third one, was to document and disseminate scalable learnings on self-injection in humanitarian settings. Next, please. Next slide. Thank you. So the key activities for the work was project introduction. where we did the district mapping exercise to be able to understand the structures within the humanitarian setting. And also we did the district entry and sensitization meeting for the district and refugee camp leadership on the right to family planning. Then we also did training, selected district FP trainers who cascaded the training to village health teams. And village health teams refer to the community health workers. These are lay people, but they are trained actually to be able to provide the services. Then the next activity was support supervision and mentorship. We did actually immediate post-training follow-ups, did monthly and quarterly review meetings on family planning services for provision to be able to follow up and ensure that the community health workers are able to provide the services. Then the next thing is that we did collect data because we wanted to understand how it works out. And most important is that the data from the community health workers had to be integrated into the routine country health management information system. Then we also did look at the supplies management. Just to mention that most of the facilities in the refugee settlements are not actually accredited to receive supplies from the national medical stores, which is the mandated system that does provide services to all public facilities. So PASS had to do some buffer supplies to make sure that the supplies are available for the community health workers and the facilities in those settings. Then we also did a lot of community awareness. And under this, we did more of community dialogues, engagement of the community, clan and religious leaders throughout the whole project. They also used interpersonal approaches by the community health workers and did male engagement so that they can actually be able to support the family planning services. Next, please. Next. Thank you. So the quick results, what we did was we did the training of considered 21 facilities. These are the ones which were participating. And again, we did training of trainers. These are basically the district focal persons to be able to do the training. So we did train 17 of them and trained 97 community health workers who are commonly here known as VHTs. And again, did support supervision visits. Next, please. Thank you. So as I said, when we did the monitoring, we found out that actually around 5,484, that's just in one quarter of April to June, around 5,484 received the services within those areas where we were working. And again, also out of these, the 5,484, we managed actually to be able to have 2,786 as DMPA units administered. Now, very interesting is that the self-injectors formed 7% of the total FP users during that period. Now, when we went to the second quarter, which is July to September, we realized actually there was an increase in all. The self-injectors moved from 385 to 1,161, which account for around 20.2%. So all in all, we realized that actually a total of around approximately 13% of the people who used family planning were actually self-injectors. This is very interesting. This was a new thing, but you can realize that within that short period, it was actually people were picking up and taking up the family planning and self-injecting. Next, please. And to mention that approximately 46% of the self-injectors were actually young people below the age of 25. So which means self-injection actually is also appealing for the young people. So what lessons did we learn from that? We noted that actually community-based distribution of family planning options, including DMPA and self-injection, it helped to increase uptake in the two humanitarian settings. So generally, because of the introduction of self-injection and working around with the structures, the family planning uptake actually increased during the period when we were working there. Then structure and refugee leadership needed to be consulted at every step of program design and implementation. For people who are well versed with the, for people who are not well versed with the refugee setting, there are some structures which are there. And we've noted that actually, if you did consult, if you did involve all those structures, you would actually be able to get good response and good support from them. Then community dialogues were key in addressing the social and cultural barriers related to family planning uptake. There were obviously a lot of barriers held by the different groups in the settlement because of the culture, because of the religious affiliations. But then we noted that during the community dialogues, it provided some opportunity for people actually to be able to discuss, for people to be able to ask questions, for people to be able to address some of those barriers, and hence allowed the people, the women, to be able to use and be able to take up family planning and self-injection. Then positioning family planning as a development issue, we found that actually it was appealing to men. We noted that actually for men, they are so much involved in something that can actually be able, that is related to income, that is related on how they can actually be able to improve their situation. So we noted that when you discuss about family planning, you needed actually to be able to relate it to how can it be a development issue. Now for the women, we noted that actually explaining some issues like the 4 twos, that is the too early, let's say too early, too frequent, or too often, then too many children, and too late. We found that actually if these concepts actually discussed and explained to the women, it makes them, gives them some bit of understanding and more information and knowledge to be able to make an informed choice on taking up family planning. Then reaching adolescents still remains a challenge, as we are aware that in these settings, we have a lot of young people and a lot of young people who are not so much engaged in some other activities. So they need actually to have like more for getting them some of the opportunities where they can actually be able to embrace the family planning. Then young women and males should also serve as part of the community health workers. This gives them an opportunity to be able to reach out to their colleagues, let's say the young people, so that they can actually be able to take up and know about family planning and know that actually they can actually be able to benefit from such. Then community supply chain tools improved accountability for supplies by community health workers and improved stock management at community level. Remember, these are community workers. Now, these people, when they are given these supplies, it requires actually to have a system that can actually be able to track the services, to track the commodities which are given to them. So that's also something which you learned as very useful. Now, the next thing which we learned from this is the community-based family planning can actually increase uptake because of its ability to consider local languages, culture shocks, and promotion of privacy. These people, the community health workers, live within their communities. They live with the people. So they are close to these people who are around them whom they serve. So it gives them an opportunity, and women actually know them, they understand them, knowing that in the refugee setup, there could actually be people from all different areas. So sometimes there are issues of languages, sometimes there are issues of cultural beliefs, But when you involve actually the same people they are on, it makes them just really feel that trust them and they can actually be able to embrace the program which you are bringing in the area. Next, please. So the number of materials, resources actually which we can be able to refer to in case somebody is interested. For safe injection resources, including safe injection program design guide, self-injection grants provide a journey map, and brief with the best practices and recommendations. Then there is also some important resource about digital training, resources for health workers and clients. And this is very important, especially in the context of the COVID-19. Then we also have a DMPA advocacy pack, and we also have some more information. If you're interested, you can reach out to me and I'll be able to give any other resources that could be of help. Thank you very much. And I wait for any other questions at the end. Back to you, Eva.
Thank you, George. That was terrific. There are lots of questions in the chat, so your presentation generated a lot of interest, and we will have time to get to those. I think in particular in the context of COVID, anything that can advance completely self-managed care is of great interest to all of us. So we'll get to those questions. Our next presenter is Jessica Kesa, and she'll be presenting on increasing access to contraception in North and South Kivu. Thanks, Jessica. Take it away.
Thank you. Hi, everyone. Thank you, Eva. My name is Jessica Kakesa, and I work with IRC as a reproductive health technical advisor. And I'm really happy to have this opportunity to share what our partners and us has done in terms of increasing access to contraception services in these settings. So IRC Care and Save the Children has worked together and supported the Ministry of Health to provide contraceptive and post-abortion care services in 3 provinces. And in the next slide, please, we will be able to see the locations. Next slide, please. Thank you. There we go. So this study was conducted in 4 health zones in North Kivu and in 2 health zones in South Kivu. And the partners I mentioned, IRC Care and Save the Children, were supporting these health zones since 2011. Next slide, please. And to give a bit of the context in North and South Kivu, so it's a place where it's known for its chronic intermittent conflict with internally displaced population, mainly not in camps, not in settlements. They live in the houses of the host community, and they face a cycle of multiple displacements and return. And at the same time, the health system is weak, and it was ranked 179 of 189 in Humanitarian Development Index in 2019. And also there is a large presence of humanitarian NGOs, including UN agencies as well. Next, please. So, like I was saying, the partners since 2011 worked with, in collaboration with the Ministry of Health to ensure good quality of contraceptive services provision. And this includes capacity building, mentoring, supportive supervision, it also includes provision of suppliers and equipment, but it also has a big component of community mobilization activities, as well as a monitoring evaluation component. Next, please. Thank you. So in 2016 and in 2017, the partners, in collaboration with the RAISE initiative at Columbia University, conducted this population-based survey, and it was to assess knowledge, attitude, and behavior of women with respect to contraception in the catchment areas that was supported of health facilities. Next, please. Thank you. So the next slide describes the methodology. I will just go through that quickly. Interviewers conducted interviews with women aged 15 to 49, and what was used was a cluster sampling. And you have more details on the slide, but for the sake of time, I will move to the next slide. Thank you. So here are the number of completed interviews by health zones. You can click again, please, to show the date for the date to appear. Well, thank you. So data collection took place in 2016 for 4 health zones, and in 2017 for 2 other health zones. Next, please. Next. Thank you. So now we are going to look at the results. Next slide, please. First, the respondent characteristics. I think the main things are highlighted in red, and we can see that mean age range from 26 to 28 years. And in Lubero, Kabare, the majority of participants were Catholics, while most were Protestant or Adventist in other health zones. And where you see other religion, for Masisi, Mweso, Kalehe, this was mostly Adventist. We can also see that half of the women in Masisi and Mweso had no formal education, and nearly half in Kaina had at least some secondary school education. Another thing is the majority of participants in each health zone, they were married, except in Lubero, where just over half were unmarried. Another thing is Masisi, Mweso, and Kalehe had the highest percentage of women who had been displaced recently. Next slide, please. Yeah, we are now going to look at the contraceptive prevalence. And next slide, please. So, yeah, when you look at this, you can see that modern and long-acting and permanent method contraceptive prevalence was higher than higher than the DHS prevalence for the provinces. So what was reported at the provincial level, we can see that in the areas where the survey was conducted, it was still higher than that. Next slide, please. Next. Thank you. And talking of the first source of current modern method, in each health zone, the majority of contraceptive users receive their method from a health facility, and of course supported by one of the project partners, so either IRC, SAVE, or CARE International. Next slide, please. Here, it shows the modern method mix. So nearly half of more of the users choose long-acting or permanent methods in all the health zone except Kabare, where it was just 1/3 of users who choose long-acting or permanent methods. And another thing to note is that implants were the most commonly used method in 5 of the 6 health zones. And over half of women in 4 health zones reported wanting to continue their method for 5 years or longer. Next, please. Let's see, look at also the barriers to the use of contraception. Next, please. So among the women who were not currently using a modern contraceptive method, the most commonly cited reasons were fertility related, including a desire to get pregnant or infrequent sexual activity. And approximately 1/3 of women in all health zones reported method-related reasons, and primarily it was side effects and opposition to the contraceptive use. And although opposition included opposition by the woman, her husband, or family or religion, most of these reported their husband was opposed to contraception. Next, please. So, in conclusion, what we can say is that these results were accomplished across all health zones, despite their varied socio-demographic characteristics and different experiences of conflict and displacement. And these findings demonstrate that women in conflict-affected areas want contraception, and they will choose to use it when they are of good quality and they are also available to them. And the findings also provide support for health system strengthening and the ways to which a strong focus on quality of care can contribute to long-term recovery in protracted crisis settings. The positive results found in this study may have taken time to achieve, and thus suggest the need of multi-year funding, but they also are more likely to be sustained as all program components were implemented in collaboration with the Ministry of Health and was conducted with emphasis on capacity strengthening of the Ministry of Health. That's all, and thank you very much, and be really happy to answer any question.
Thanks, Jessica. That was terrific, and what a beautiful slide to end with. I'm sure that there will be plenty of questions coming up in the chat, and then we'll address them at the end. So our last presentation is also from IRC, and this is a presentation about integrated women and girls safe spaces in Bangladesh. And our presenters are Nasreen Akhtaromi and Terry Alobi. And don't worry if there's kids come in the background and things, it's not a problem, but if you don't have bandwidth for your video, you also don't need to put it on. Take it away. Nasreen or Terry, are you there?
Hi, can you hear me?
We can hear you just barely. Not well. That's good.
How about now?
Yep, that's great, Nasreen. Thanks.
Thank you. Can you see me? I'm not sure.
We can't see you, but we can see your slides. Your video is just a black screen.
Okay.
There you are.
Okay. Hi. So thank you so much for the opportunity given to IRC Bangladesh team. And today I'm presenting SRH and GBV service delivery through integrated women and girls safe space in Bangladesh. The IRC Bangladesh is operating women and girls safe space since 2018. The main objective of Women and Girls Safe Space is to explore the benefits of risk of SRH and GBV integration and risk of SRH and GBV integration using women-centered programming with the aim of increasing access and agency. So for the next slide, I'm handing over to my colleague Terry. Over to you, Terry, for the next slide.
Thank you, Nazreen. So in the Women and Girls Safe Spaces, we have a number of services that are integrated. So basically it's GBV and SRH. So for the GBV, we have GBV case management. So under GBV case management, we have GBV screening, we have structured PSS, as well as one-on-one psychosocial support. We also have referrals that we do to other partners. We have follow-ups as well as transfers. We also have dignity kit distributions. This is upon assessment, so it's on need basis. And then for the SRH services, we do have clinical management of rape. We also have voluntary contraception services. We have safe menstrual regulation. We have post-abortion care and syndromic management of STIs. So Nazreen will take us through the trends analysis and just take us through the data of the SRH data. Sorry. Back to you, Nazreen.
Thank you, Terry. So you can see that the research data I'm presenting in this presentation. And this data is analyzed from only 2 camps where target population are same for both women and girls safe space and traditional health facilities. So in this data shows higher utilization of SRA services provided in women and girls safe space than from our traditional health facility. Here you can see 63% of family planning services provided through women and girls safe space and only 37% provided through traditional health facility. And for STI, almost 89% provided through women and girls safe space, and only 11% were provided through traditional health facility. And it is also seen increase in women seeking CMR services within 72 hours at WTSS. Next slide, please. Thank you. So this pie chart shows services uptake rate by adolescents. We can see from this data 92% of adolescent services assessed from women and girls safe space, and only 8% services were accessed through traditional health facilities. This also this also shows that adolescents or young group are more comfortable accessing SRH services in women and girls safe space compared to health facilities. Next slide, please. Thank you. And this, you can see the curve. This is the service delivery curve during COVID, where we can see declined number of services in both type of facility, and it is due to many reasons, such as stopping of outreach activity, which was given a negative sense of service availability in the facility, and all services were available, but facilities opening are in women and girls safe space were reduced, while it was unchanged in PSCC, and also no, like in women and girls safe space, there are usually one provider. So whenever she is in leave, the services are not available there. And also we operate 22 days a month, where on other hand, PSCC, like the services are available 24/7 and all day in a year. And we also know that services have picked up again, and we are back to normal now, and the data represent that with the curve. If you can see the curve, it's like in increasing in manner, and now the women's started coming back to assess the services, and we have resumed our outreach activity. You can see the data till June. July data is not presented anyways, but now we can see that in July our women's and girls are assessing services like before. Now, Terry, over to you.
Next slide, please. So for our qualitative findings, we have the women and girls prefer the integrated safe spaces because it is a one-stop shop. Why we call it a one-stop shop is that the services there are integrated. So women and girls are able to get the services at one place without moving from one center to another or one partner to another. So what happens is the women and girls feel more confident and actually feel that the confidentiality is strengthened, and also it reduces the stigma. So like you don't, for example, I'll just give an example. If you have a rape survivor, she doesn't have to move out of the women and girls safe space to seek for health services. It's all integrated in the women and girls safe spaces, so she will get all the services there, and she leaves, it's a whole package, she leaves with everything done, and no one has to tell that, you know, with the movement and everything, it's limited, so no one tells what has happened. We also have the women and girls safe spaces has actually created a safe space for women and girls to just interact and create wider social networks. One thing is that as the women and girls safe spaces, women and girls don't come just for services. It's their space. This is a place where they come and sit down, unwind, talk, laugh, and just enjoy their space. This is their space. And then lastly, we have the women and girls have a sense of ownership. From the onset, that is establishing the women and girls safe spaces, we do needs assessment where we consult and involve the women and girls in the whole process. This helps to create an opportunity for them to raise their voices, identify their immediate needs, and just provide possible solutions from them, bearing in mind we use the survivor-centered approach. So they're able to, in quotes, custom make the women and girls safe spaces to what feels safe for them, to what they want. So it gives them a sense of identity and responsibility that this is our space, they own this place. Next slide, please. We can say that the women and girls safe spaces has created opportunity for women and girls in a way that when they come here, they get to learn. We have livelihood opportunities for women and girls. We have vocational and socioeconomic skills, vocational trainings. So women are able to learn, they learn income generating skills, which empowers them and just builds their self-esteem. They feel like, yes, now this is our space. We have learned a new skill. So they feel empowered. Secondly, the women and girls safe spaces as compared to the health facilities, there's consistency of service providers. So it's not rotational, unlike the health facilities and the PHCCs, where the staff are on a duty roster. Here, the staff are actually the same staff, they're not rotational. So the survivor does, and the women and girls do not have to narrate their cases and have to rebuild their rapport with other staff service providers. Like today we have someone new, today we have Eva here, tomorrow we have Terry, tomorrow we have Nazreen. No, the fact that we have consistent service providers actually makes the women and girls safe spaces more convenient. Then lastly, we have the fact that we have proper SOPs, guiding principles, and that are adhered to by our trained staff. It actually helps the integration and how different sectors collaborate in providing services of the women and girls safe spaces, as each and every staff being trained and having refreshers understand their roles and responsibilities. So this gives a very high quality, not only expertise, but also the implementation. The quality of service we give is quite high because everyone understands their roles and responsibilities, how they collaborate, how they integrate. So it brings out a very, very strong and quality service prevention. So over to you. We will wait for the Q&A. So back to you, Megan and Ava. Thank you.
Fantastic, both of you. Thank you so much for sharing that really unique program and the results. That's terrific. So we have about 15 minutes for Q&A. There are lots of questions in the chat, and I think I'll go back to the beginning and start with Jillian, and then I'll jump around. So it seems eons ago that Jillian presented, but Jillian was talking about Ebola in Sierra Leone. And I think for me, one question I have for you is, how do you, maybe it's two parts of one question, how do you think about these findings and your results in the context of other Ebola outbreaks that weren't in Sierra Leone? And second, how do you relate your findings to the current pandemic and the COVID pandemic? And are they useful at all? And can they inform how we move forward in terms of contraception access in the context of COVID? Jillian, if you're still there, I'll hand it to you. Okay.
Yeah, as long as you can hear me. Thanks so much. Yeah, I mean, two great questions. I mean, I was very fortunate to be able to go to the DRC in the last Ebola outbreak. I mean, fortunate's an odd way to put that, isn't it? But it was nice that I was able to go and see a different outbreak and see how these findings might still apply in that setting. And I think, you know, they really did. They were very much the same. Women's fears around unexplained bleeding were huge in their mind's eye whenever they were thinking about going into care to seek care, whether it was for breakthrough bleeding, for family planning. Although I did a piece of research that was much broader than that, so it also impacted women's decisions to seek care for spontaneous abortion, potentially, you know, really impacting their health if they delayed to do so, as well as for pregnancy. So this kind of Ebola context and this misappropriation sometimes of the term unexplained bleeding in the case definition does lead to kind of really negative consequences for women when they're afraid to seek care, and when healthcare workers don't know how to ask the right questions to be able to kind of nuance the problem. For COVID, you know, it's interesting. I think I came into COVID thinking it's going to be super applicable. And the more that we're in this COVID outbreak, I think some things do apply, but a lot don't. COVID is a very different disease. It's a respiratory disease. It doesn't lead to the same kind of conflagrations of like bleeding and disease. So you do have some really serious differences there. And, you know, while at the beginning I was like, this is a great way to make sure that we're providing care outside of health facilities if women are afraid to go to them. In conversation with field teams, they're saying, you know, that's just not possible. We can't do that. We don't have sufficient PPE. We don't have sufficient training. And we've got to be really careful about doing that, because healthcare workers themselves are not only put at risk, but potentially could be putting a lot of other people at risk as well, if we're getting them out of the health facility. So I think that, you know, it's a little bit of both. You know, some outbreak stuff is universal, that there will be fears of health facilities and that there will be access restrictions, but also, you know, we have to really think about the disease and how it interacts with the particular reproductive health system.
That's great. I think that you bring up some excellent points there. And I think it also reminds us that we have to get unique data from people who are experiencing the COVID pandemic and not just sort of blanket apply findings that we have from other epidemics. So that's an excellent point, Jillian. George, I'm going to jump to you. There's a lot of interest, no surprise, in products that allow for self-managed care in the context of COVID. So there are a few questions for you. I'm just going to batch two of them together. One is about how you see the facilitators and barriers to uptake of self-injection itself. Clearly, there was a lot of interest in the product of DMPA-SC. And you saw a limited interest in self-injection or uptake of self-injection, and then you saw a jump in your second quarter. But still, of the proportion of women who chose the method, a small proportion of them chose self-injection. So I'm interested in what you see as things that facilitate and make it more complicated to choose self-injection. And then second is in the context of COVID, I think we're all really interested in products that allow for completely self-managed care. So how do we bring something like this to scale when we have a pandemic of this size? Those are two big questions. Go ahead.
Thank you, Eva. I think, as you say, because of the pandemic, we have learned a lot of things. And there are efforts actually to try to look at how do we provide services within the context of the COVID, which is a global pandemic and a global challenge. One of the questions on the facilitators, I think the 7 and 20%, I think for us, it will be good, because remember, we are talking about in the context of the method mix. So which means that it is allowing actually the other people taking up the different methods. And we have seen that even outside the humanitarian setting, it moves actually, it is around that percentage of around 15. So, and these are 15, we are talking about around 13 rather, 10 to 13. So if we are seeing 10 to 13, and we are seeing in the humanitarian setting 20, so which means actually in the humanitarian setting, it is actually higher. But also remember that if we are talking about a method taking up around 10%, that's quite actually big. However, if you look at the facilitators and the barriers, they are quite, as I elaborated, there are things which we learned. Like, for example, enabling the people to understand, the women, explain to the women to understand, so that they are able to make an informed choice. One, about the method as injectables. Fortunately, in this area, I think the injectables almost take around 50%. So it is one of the methods actually which is common and which is more acceptable here. But one of the things which we look at the facilitators are the issues of saying, making sure that people are, the women are aware of us, are explained, are informed, are explained on the different, for example, side effects, but also training them, because that's one of the issues. Training obviously takes a bit of time to be able to train these women, but also explaining to them that, look here, if you take some time, but I train you, then it means on the subsequent, you don't need to come back. Just to mention that the women are trained in a facility, and on the first injection, they give it under the supervision of the health worker. Now they are given 2 units. So which means this actually takes the person, a woman, around 9 months without coming back to the facility, unless she has any other reason of why she has to come back or any other concern. So that's one of the things. However, some of the barriers, as we have mentioned, those are issues like cultural beliefs, people not having adequate information. There are a lot of misinformation in the communities. So people will actually be able to talk about issues, talk about all the other related misinformation, and which actually make the people not get the information. But something also which we learned is that most of the women, because they don't get quick access to information, so most of the information which they have is actually from their colleagues, their peers. So which most of the time is actually wrong. So that's one of the things I think which we looked at. But also, as I said, the cultural leaders, the religious leaders, all different affiliations actually also have a very strong influence, especially in the group which we are working in the people from South Sudan.
Thanks,
I
George.
don't know if I left out any question.
No, that's great. I mean, I think we could talk about this just DMPA for some hours, and each one of the presentations the same. So I think that's great. There's a lot of interest, and it's interesting. You comment on training takes time. It does, but it's a one-time thing, so you can sort of buy yourself some time at the beginning, and then she's not coming back to the facility. So I appreciate that reminder to all of us. Thank you, George. You have a couple more questions, but I'm going to jump to Jessica for a second and then come back to you. Jessica, I hope you're still there. I'm going to pose two questions to you. One is in the chat from Lorelei, and that is, why do you think your survey results showed higher rates of modern contraception use than the 2014 DHS results? Do you have ideas about how the DHS could better represent FP-related results for women who've experienced displacement in the last 5 years? That's one question, which is in the chat. And do you want me to give you the second one so you can batch them both, or do you want me to hold?
Yeah, sure.
The second is
from me. Give the second one.
From me, and that's my question about, you had high implant uptake compared to other methods, if I'm interpreting your graphs correctly. I'd love for you to comment on why you think that is, why you think implants were so popular, and whether or not you can comment on the availability of removal services in those same settings, including for deep implants. Thank you. Take it away.
Thank you very much for this great question. Well, for the first one, like I mentioned, the catchment population where the study was conducted, where the partners were supporting the health zones. And in one province, you can have up to 50 health zones. So we were just supporting, I could say, a small portion of the total province. That's why when you look at the result on the DHIs shows that we're showing results at the provincial level, and they capture for the total population. And when you compare where we were providing support, that's what explains the difference. And remember, I mentioned that the health system was still weak, so they didn't get the same amount of support in terms of capacity building, in terms of suppliers and equipment provision, in terms of also of activity on community mobilization. So this would explain, again, the difference on women accessing these services. For the second question, so it was like, yeah, implant is a common method, and we have asked ourselves so many questions around that, trying to understand why women would choose implants. And I think I have to admit, when we sat down as a team and look at the results we were getting, somehow there are also a component of providers' bias towards women using one specific method, because ideally we could see like an even distribution among all the different other methods. So we had put in place action to address those bias. For example, training on balanced counseling to make sure that the woman is given a choice, to make sure that suppliers are available, they are not stock out, so she has a choice to choose, and also work again on information that we are providing within the community on the different methods that exist. And you have noticed surely that even IUDs at the beginning, we couldn't even see one user of IUD. So we had also to work on that, working with providers, make sure that they felt comfortable, because when you have a competency and then 3 months, you spend 3 months without offering the services, then you are not competent anymore. So we had also to work with providers, making sure that they feel also comfortable providing these services. We saw a bit of change throughout the years of the method mix, with more women using other methods, including IUDs. But still, the implant was the first method. And I can say it has also to do with behavioral component. Like if from the beginning, in the community, women, they heard from other women that, well, I'm using an implant, go to the facility for the implant. We had that also a lot, and I think to change that, a behavioral thing that is, I think, would take more time and more other components to change that. Yeah, this is what I can say. You also say something on removals. Yeah, so when training providers, they were trained both on insertion and removal. So removal services were available, and I didn't mention that, but services were free of charge. So even removal was free of charge, and women could come for removal anytime they wanted to. But one thing I can mention is that we noticed at one point that we had a big number of removals. So at the same time they were coming, and then we could see again women removing, and well, they were saying the main reason was for fertility reasons, but when you prompt and try to really understand, oh, they were saying personal reason, and you try to really understand, we found that side effects were one of the reasons why they wanted to come and have it removed. So we had also to work with providers on how, first, to do a better counseling to inform on side effects, but also how to manage side effects so women could. She had all the benefit to get women protected from a pregnancy. So yeah, this is what I can say on.
Yeah, no, that sounds like, it sounds to me that you all did a tremendous amount of sort of reflection on the method mix trends and why, and keeping your eye on removals and access and things like that. I certainly don't have a skewed method mix. It's just caught my eye as being interesting, but it sounds like you were all over it and very aware of wanting to look into the reasons for why women were choosing what they were choosing. So that's fantastic. Why don't we end with one last question for Nasreen and Terry. You had a couple of questions in the chat which you answered, so I won't repeat those. And George, you have a couple outstanding questions in the chat regarding tracking self-injection and regulation, and you might want to type in answers for those if you can. And I'll just end with Nasreen and Terry. And my question for you all is, this is a really incredible and promising project and study. What are your next steps? Do you have plans to expand? Do you have plans to do more study? Because clearly there is a lot of interest in the areas where this is available. Over to you.
Yes, Eva, I'll respond and Nazreen can add to that. So yes, we do have plans of expanding. Currently, we have a women and girls safe spaces being established in a new camp where we did not have one. And secondly, we do have prevention strategies that go along with the response services that we do at the women and girls safe spaces, but actually involve the partners. So basically, just to also comment on a question that was in the chat box, like how do we trace maybe like the partners? We have like men being an agent of change, and we do have some strategies that do involve the male. So like we have IMAP, which is engaging men through accountable practices. So this is a structured program model which usually targets the men for transformational attitude and behavior change, which is guided by the voices of women and ensuring that accountability for women and girls. How we engage the men, being a patriarchal society, we actually have this transformational attitude and behavior change, which is influenced and guided by the voices of women and girls, which has a great impact in generally the Bangladesh context. So yes, we do plan on expanding, and we are expanding, and we do have prevention strategies that actually link to the women and girls who are the women and girls safe spaces and to the men outside. So we have SASA, where we involve community leaders who are influential, again, in the context. We have IMAP as well, and then we have EASE, which is an economic module that we also use to empower the women and girls. Over to you, Nazri.
Thanks, Terry. Additionally, yeah, we are planning to do something new as we are doing a different type of project integrated with women safe space, that is like on contraceptive. We are thinking to, it's not thinking, we have started, I will say, to engage women and girls who are just newly married, and women who will be giving birth or planning to do family planning. Our plan is to engage them in a session, in a like couple number of session with them, with their family member, with males, through these women and safe space, and link those women and girls to nearest health facility where they can they can get the other services that are not available in women safe space. Thank you. Any other questions? I'm happy to answer.
Thanks, Nasreen and Terry. That's fantastic. I'm excited to watch this project grow and hear more, maybe at the IWAG meeting when we can be in person, which of course we're all looking forward to. I think we're at time, everybody. Thanks for joining. We had close to 40 participants at one point. I know some people have had to drop off with reaching the half hour. This was recorded, so hopefully this will be available through some channel for people who weren't able to get on. And there are other webinars in this series addressing other areas of the work within the IWAG. So thank you so much all for joining, and in particular to the presenters and your teams who made the work possible. And with that, I'll sign off and wishing you all the best.
Thank you very much.